Hello friends, I am Dr. Bhumika D. Patel, Assistant Professor, Department of Pharmaceutical Chemistry, Institute of Pharmacy, Nirma University, Ahmedabad, with interesting and learning episode of B.Pharm on the important unit of sulfonamides from the section of Medicinal Chemistry 3, Semester 7, which is prepared by myself and Professor Manjunath Ghate, Professor and Head, Department of Pharmaceutical Chemistry, Institute of Pharmacy, Nirma University, Ahmedabad. So let us start our episode by taking a look at what we are going to learn today. Module 1 is the development of sulfonamides. Module 2 will be nomenclature and classification of sulfonamides. Module 3 is antimicrobial spectrum. Module 4 is mechanism of action. Module 5 is the uses of sulfonamides. Module 6 is the drug resistance of sulfonamides. So let us begin with module 1, that is development of sulfonamides. First of all, we will start with the history, development and general introduction about sulfonamides. The years around 1935 saw the discovery of prontosil, which is a red azo dye, and its use in medicine as early antibacterial agent. The German pathologist Gerhard Domecq from 1895 to 1964, during the screening of several agents for anti-streptococcal activity, found that the prontosil gave good antibacterial effect. His results, published in February 1935, can be summarized as follows. Number 1. A strain of Streptococcus hemolyticus originating from a lethal case of human sepsis was used as a new disease model in mice. All infected animals died within 1 to 2 days and showed streptococci in blood and tissues. Number 2. Some gold compounds as well as acridine and azo dyes showed chemotherapeutic activity in vitro, but they were toxic or inactive in vivo. Number 3. The azo dye prontosil, even though inactive in vitro, had the pronounced chemotherapeutic effect ever observed in vivo. All infected animals survived without symptoms. Streptococci had disappeared and leukocytes showed signs of increased phagocytosis. Number 4. The toxicity of prontosil was very low, 1000 mg per kg being tolerated without any side effects. Clinically, he treated his own daughter who might have been suffered and then saved from the threatening consequences of septicemia by prontosil injection. Clinical use of prontosil soon spread from the Germany across the borders. In 1939, Domecq earned a Nobel Prize in Medicine for this important discovery, but an order from Hitler prevented Domecq from accepting this honor. The fact of only in vivo activity and inactivity in vitro supports the idea that prontosil exerts its action after in vivo activation by the host metabolic pathways to give the active form. The active form is sulfanilamide, which acts by interfering with para-aminobenzoic acid, that is PABA, utilization by the infecting bacteria. This is shown in the figure. The second act happened at the prestigious Institut Pasteur in Paris. Domecq made his discovery of prontosil in 1932, but published it only in February 1935. However, from 1933 onwards, some clinical papers appeared in Germany without mentioning prontosil or its formula specifically, which might have been a sign that something new was brewing. A patent on prontosil was published in 1934 and later in 1935, only 9 months after the appearance of Domecq's classical paper, the key work of Institut Pasteur Group appeared under the title, that is Activity of Sulfonamides on Experimental Streptococcal Infection of Mice and Rabbits. Much of this work was based on Domecq's discovery. It was much more than just another discovery. In fact, it contained a key to the development of bacterial chemotherapy and thus belongs to the great text of modern medicine. Its clear style and extreme density of invaluable information makes it a masterpiece in form as well as in content. The results can be summarized as follows. The introductory paragraph gives full credit to Domack and immediately reveals an extensive screening for anti-streptococcal activity in vivo within selected azo dyes of Prontosil-like formula as shown in figure. The following relationship with respect to sulfonamide group replacement emerged from it. The one is if SO2NH2, that is the sulfonamide group, if it is replaced with methoxy, that is OC2H5, or with cyano, that is CN, or with methyl cyano, that is CH2CN, or with amide group, that is CONH2. So, in general, if sulfonamide group is replaced with any of this functional group, it leads to inactive molecules. Since all dyes containing a sulfonamide group on one of the benzene ring were active regardless of the substituents of the other ring, the authors assume that the compounds in the body undergo a splitting of the azo bond according to the figure 1 present into the prontosil. Indeed, sulfanilamide as the common cleavage product of the above sulfonamide compounds has a pronounced chemotherapeutic effect on the streptococcal infections comparable to prontosil. Again, blood cultures were totally negative. The toxicity of sulfanilamide was very low, 1000 mg per kg being tolerated without any side effect. Derivatives of sulfanilamide, if substituted in the sulfonamide nitrogen, were also found active. The final paragraph stated that the activity of sulfanilamide as a simple molecule which is not a dye will allow a systematic chemotherapeutic study. Thus, scientists working at the Pasteur Institute in Paris who tested sulfanilamide found that it was an effective as well as the parent dye stuff in protecting the mice infected with streptococci. They also showed that sulfanilamide exerted a bacteriostatic effect in vitro on susceptible organisms. In 1936, it was showed that sulfanilamide could cure streptococcal and meningococcal infection in mice. Thus, the era of modern chemotherapy had begun and sulfanilamide, being easy to prepare, cheap and not covered by any patents, become available for widespread use and brought a new hope for the treatment of microbial infection. After sulfanilamide discovery, another report by the same team, that is the team of Paris Pasteur Institute, published in 1936, gave more detailed information on structure-activity relationship of 130 tested compounds, among which 46 were totally sulfanilamide derivatives. Later, thousands of chemical variations were studied and the best therapeutic results were obtained from the compounds in which one of the hydrogen of sulfanilamide group or sulfonamide group, that is SO2NH2 group, was replaced by heterocyclic ring. The analogues and the derivatives of sulfanilamide were developed particularly with a view to have lot of purposes. I am going to list out these purposes. Number 1, to enlarge the antimicrobial spectrum. Number 2, to improve the therapeutic index. Number 3, to increase the permeability and distribution in the body fluids and tissues. Number 4, to increase half-life to reduce the frequency of administration. Number 5, to increase water solubility both of the parent compound and its metabolites to reduce tendency to crystalluria and to reduce toxicity. And last, number 6, to delay the emergence of resistant strains and to improve the activity against resistant organisms. The SAR of different analogues was studied and next generation sulfonamide became available in market as shown in figure, as well as it is discussed as below. The first molecule was sulfapyridine, which was discovered in 1938. It was introduced for the treatment of pneumonia. After that, sulfathiazole, which was found to have higher therapeutic index. Then sulfadiazine with broad antibacterial spectrum, high in vivo activity and low toxicity, as well as it is having relatively longer duration of action. After that, the next was sulfamerazine. It is a methylated derivative of sulfadiazine with greater solubility in water at pH 7, as well as it is more quickly absorbed and more slowly excreted than sulfadiazine. After it, next sulfonamide discovered was sulfamethazine, which is again a methylated derivative of sulfadiazine, even more soluble than sulfamerazine at pH 5.5. After it, the next comes sulfamethiazole having low minimum inhibitory concentration, that is MIC, having higher solubility, quick absorption and rapid excretion, and find it use in kidney as well as in urinary tract infection. Next comes is sulfazoxazole, which is having significant activity against Proteus vulgaris and E. coli. After that, sulfacetamide came into the picture with high soluble non-irritant neutral sodium salt, which is quickly absorbed, rapidly excreted without danger of any crystal urea problem into the kidney, widely used in ophthalmic practice. Next comes sulfamethoxypyridazine in 1956. It was the first long-acting sulfonamide with half-life of 37 hours. It was introduced in clinical practice and it was needed to be administered only once a day. After that, another longer acting sulfonamide came into the picture, that is sulfamethoxydiazine in 1961. It is having a half-life of around 35 hours. So, also it can be one of the longer acting sulfonamide. Another longer acting sulfonamide was sulfadimethoxine with half-life of around 40 hours. Another one is sulfamethoxypyrazine with half-life of 65 hours. Now, the longest or ultra long acting sulfonamide, that is sulformethoxine, came with a half-life of 150 hours, which is the highest one. It was supposed to be taken once in a week and it forms a very suitable combination with pyrimethamine for the treatment and prophylaxis of malaria. Sulfamethoxazole came later. It was the broadest antibacterial spectrum sulfonamide and it is having lowest MIC value. Its half-life was around 11 hours, but it was the broadest antibacterial spectrum compound. That was the excellent part of sulfamethoxazole. Then the combination of sulfamethoxazole with trimethoprim comes into the picture in 1960 as cotrimoxazole, which was used for HIV infection, burns and urinary tract infection. The combination, which is known as cotrimoxazole. Thus, with plenty of sulfonamides into the picture, the discovery of sulfonamides was the start of modern antibacterial chemotherapy and gave credence to the magic bullet ideal in drug design. After the discovery of sulfonamides, another class of sulfonamide came into the picture, that is the sulfone. The demonstration that experimentally induced tuberculosis could be controlled by 4,4-diamino diphenylsulfone. The chemical name is 4,4-diamino diphenylsulfone, and the general name is Depson. We all know that Depson is a very good agent for the treatment of leprosy nowadays. But when it was introduced, it was the first sulfone derivative. So it was the molecule which came into the picture for anti-tuberculosis treatment, but it was not giving good effect in anti-tuberculous activity. So although Dapsone proved disappointing in the therapy of human tuberculosis, the interest aroused in the possibility of treatment of mycobacterial infection with sulfone led to the demonstration of the favorable effect of Dapsone in rat leprosy first and then into the human patients. Now, Dapsone has remained since its discovery the only drug and the most popular drug of choice for the treatment of human leprosy. This is the end of module 1, that is the history and development of sulfonamides as well as sulfone. After this, in module 2, we are going to discuss on nomenclature and classification of sulfonamides. So moving on to the next module, that is around the nomenclature and classification of sulfonamide. Sulfonamide is a generic term that denotes antibacterials that are aniline substituted sulfonamides, that is the para-amino-benzyl sulfonamide or sulfonilamides. They are the prodrugs that react to generate active sulfonilamide. They are the derivatives of sulfonilamide as shown in figure. You can see into the figure where the general structure of sulfonamide is shown. Specific compounds are described as N1 or N4 substituted sulfonilamides depending on whether the substitution is on the sulfonamide amino group or on aromatic amino group respectively. Most of the sulfonamides used currently are N1 derivatives and not the N4 derivatives. Classification of sulfonamides are based on many types. So we will see this classification one by one. The first classification is based on structural variation, where first class is N1 acyl derivatives. Here the substitution is on N1 amino group, that is the amino group which is the aniline amino group, and the example is sulfacetamide. Next class is N1 heterocyclic derivatives containing 6-membered heterocyclic rings. Examples of such sulfonamide derivatives are sulfadiazine, sulfisomidine, sulfapyridine, sulfamerazine. You can see the structures of all these sulfonamides in a figure. Next class is N1 heterocyclic derivatives containing 5-membered heterocyclic rings. The examples are sulfathiazole, sulfamethiazole, sulfamethoxazole, sulfisoxazole. Next class is N4 substituted derivatives. These are the prodrugs. Prodrugs means prontosil. As we have seen earlier that prontosil is a prodrug which gets activated in our body by the metabolism. Next class is N1 and N4 substituted derivatives. The examples are succinyl sulfathiazole, phthalate sulfathiazole and sulfasalazine. These all are substituted at both the position N1 as well as N4 amino group. The next class is non-aniline sulfonamide, and the only example under this category is mefenide acetate. And the last class is sulfone derivatives. The example of it is Dapsone. This is the end of first classification, which was based on structural aspect. The second classification of sulfonamide is based on duration of action, spectrum of activity and therapeutic application. So now based on that, the first class is short acting sulfonamides. These are the molecules with a half-life less than 10 hours. These are preferred for the systemic infection as they are rapidly absorbed and rapidly excreted. The examples under this category are sulfamethiazole, sulfisoxazole and sulfonilamide, which have been used for the treatment of urinary tract infection. The second class is intermediate acting sulfonamides. So here the molecules are having half-life between 10 to 24 hours. These are mostly used for infections requiring prolonged treatment. The examples are sulfamethoxazole and sulfadiazine, which have been used for various infections, especially active against invasive aspergillosis in AIDS patients. The next class is longer acting sulfonamides. Here the sulfonamide molecules are having half-life longer than 24 hours. These are rapidly absorbed and slowly excreted. The examples are sulfadimethoxazine and sulfadoxine, which have been used for the treatment of ulcerative colitis. The sulfadoxine is the ultra long lasting sulfonamide which is often used in combination with pyrimethamine to treat or to prevent malaria. It is also used usually in combination with other drugs to treat or to prevent various infections in livestock. In addition to this, there are different types of other sulfonamide derivatives which have been used in various types of infections such as for mucous membrane infection, sulfabenzamide, for superficial ocular infection, sulfacetamide, for urinary tract infection, sulfadiazine, and as anti-cancer or some other treatment, sulfamethiazole. So with this, we came to the end of classification and nomenclature of sulfonamides and we came to the end of our module 2. Let us start with module 3, that is antimicrobial spectrum of sulfonamides. The antimicrobial activity of sulfonamides extends to a number of microbial species having a folic acid pathway, which includes many gram-positive and gram-negative cocci and bacilli, mycobacteria, some large viruses, protozoa and fungi. In all cases, their action is related to PABA antagonism. Thus, sulfonamide are broad spectrum bacteriostatic antibiotics. Individual sulfonamides do differ in their antibacterial spectrum, but these differences are more quantitative rather than qualitative. If we list it out, gram-positive bacteria which are susceptible to sulfonamides, in gram-positive bacteria it includes group A, Streptococcus pyogenes and Streptococcus pneumonia. If we list out gram-negative organisms, it includes Meningococcus, Gonococcus, E. coli, Klebsiella, Salmonella, Shigella and Enterobacter species. Other than gram-positive and gram-negative organisms, the susceptible organisms are Bacillus anthracis, Nocardia, Actinomycetes, Chlamydia, Trichomonas and some protozoa. Plasmodium falciparum and Toxoplasma gondii are also susceptible against the sulfonamides. E. coli frequently is susceptible when present in the urinary tract, particularly if the organism is community acquired and the infection has not been treated previously. Klebsiella species, Proteus mirabilis and Serratia marcescens vary in their in vitro susceptibility. Diseases caused by Enterobacter aerogenes, Pseudomonas aeruginosa and other Proteus species seldom respond to sulfonamides. With this, we came to end of module 3. Next is module 4, which is about the mechanism of action of sulfonamides. So let us start with that. In reference to antibacterial activity, sulfonamides are structural analogues of PABA, which is the normal substrate for dihydropteroid synthetase, that is DHPS, for the synthesis of DNA in the bacteria. Sulfonamides are competitive inhibitors of dihydropteroid synthesis, which is a vital enzyme for the synthesis of tetrahydrofolate, which is known as coenzyme F. This coenzyme F or tetrahydrofolate is important for pyrimidine nucleic acid synthesis in bacteria. If will inhibit the synthesis of tetrahydrofolate, the bacteria can no longer grow and divide, which gives time for the host immune system to destroy this bacterial cells. This is shown into the figure. This means that sulfonamide bind in the same manner as that of PABA. They compete with PABA for the enzyme dihydroteroate synthetase, and as result, the growth of bacteria inhibited because of inhibition of formation of dihydrofolate. Tetrahydrofolate and subsequently bacterial DNA is also going to be inhibited. This binding is reversible, and so that they have bacteriostatic effect, not bactericidal effect. This is again shown in a figure where we have seen the PABA versus sulfonamide in the active site of dihydroteroate synthetase. There are metabolic differences between bacterial and mammalian cells. The sulfonamides are selective for a key reaction found only in bacteria. Most bacteria synthesize their own folic acid, while in contrast in humans we obtain our folic acid from food and vitamin supplements. Dihydroteroate synthetase is present only in bacterial cells, while a special transport protein for folic acid is only present in mammalian cells. In humans or in mammals, the cell synthesizes tetrahydrofolate from the folic acid which is obtained from diet. This folic acid is normally transported to inside the cell by a special transport system which is absent in bacteria, and that's how this sulfonamide are selective only for bacterial cells and not for the human cells. This is shown in a figure where we have seen mammalian folate biosynthesis pathway which we can correlate with the mechanism of action. This is the end of this module. In the next module, that is module 5, we are going to discuss uses of sulfonamides. The number of conditions for which sulfonamides are drug of first choice has declined nowadays because of a gradual increase in the resistance against them, as well as the addition of newer classes of antimicrobial agents also restrict the use of sulfonamides, but they still have a distinct and significant place in therapeutics due to the wide choice of agents with greatly different half-life and pharmacokinetic characteristics. They also have some more characteristics like they meet the requirements of varied clinical situations, they have a wide antimicrobial spectrum, they have benefits of synergistic action, that their combination with dihydrofolate reductase inhibitors provides the high selectively action on the microbes with minimal side effects onto the host. They also are having relative freedom from problems of superinfection. They also have ease of administration and favorable pharmacoeconomics. So with lot of reasons, that's why the sulfonamides are still in clinical use. Sulfonamides can be used systematically, topically or orally for the local effects depending upon their solubility. Some of the uses of sulfonamides are listed as below. Pneumocystis carinii pneumonia, for this trimethoprim and sulfamethoxam combination is widely used. In urinary tract infection, sulfamethiazole is widely used, while for nocardiosis, sulfadiazine and sulfazoxazole are being used. In dermatitis, sulfapyridine, or in meningococcal infection, sulfadiazine is widely used. In topical burn therapy, silver sulfadiazine, mefenide acetate is being used. For conjunctivitis and superficial ocular infection, sulfacetamide is being used. In GI tract infection, sulfaguanidine is being used. In chloroquine resistant malaria, sulfadoxine with pyrimethamine is used. For intestinal infection or for ulcerative colitis, sulfasalazine is used. In Haemophilus vaginalis vaginitis, triple sulfa, that is the combination of 3 sulfa drugs, sulfabenzamide, sulfacetamide and sulfathiazole are used. In the treatment of toxoplasmosis, pyrimethamine sulfadiazine combination is used, while in leprosy, dapsone is being used. So, with this, we came to the end of uses of sulfonamides. In the next module, module 6, we are going to discuss drug resistance of sulfonamides. Emergence of drug-resistant strains of parasites is one of the major limitations of sulfonamide therapy. The development of resistance is considered to arise owing to one or more of number of factors. The factors we are going to see right now. The first can be mutation that cause overproduction of PABA, and the affinity of PABA with dihydroteroid synthase is 5,000 or 15,000 times more strong than that of sulfonamide. The next reason can be mutation in the dihydroteroid synthase gene, which results in altered sensitivity of the enzyme, which makes it selectively more sensitive to the natural substrate PABA. Another reason can be loss of permeability to the sulfonamide or efflux pumps. Another reason can be gene amplification of the enzyme so that more enzyme is produced, thus rendering its saturation by antagonist difficult. Another reason for resistance can be mutational or recombinational changes in the target enzymes, and also it can be acquired resistance by drug resistant target enzymes. In bacteria, the first two mechanisms, that is the overproduction of PABA and causing point mutation that reduce sensitivity of the dihydroteroid synthase to the sulfonamide, seem to be most common. A single point mutation can confer resistance to sulfonamides. Different sulfonamides show cross resistance, but there is no cross resistance to other antibacterial agent has been observed. Resistant strains developed by random mutation and selection or by transfer of resistant factor by plasmid from resistant to susceptible strain by conjugation. Thus, resistance to sulfonamide is both chromosomally and plasmid mediated. Mutations are prevalent in nature among many clinically important bacteria like E. coli, S. aureus, S. hemolyticus, Campylobacter jejuni, Helicobacter pylori, etc. Resistance emerged gradually and is widespread in many animals. In Plasmodia, in addition, resistance appears to be due to a bypass mechanism, that is the ability to use preformed folic acid. Bishop has described strain resistant to both sulfonamides and pyrimethamine that can presumably utilize the reduced forms of folic acid available in the host erythrocytes. With this, we came to the end of resistance of sulfonamides. So, in conclusion, the interest in sulfonamides is still persistent since their discovery. About 20 sulfonamides constitute the most largely used drugs of this group. They vary widely in their absorption, distribution and excretion pattern, which has greatly increased their scope for clinical use since 1968. In prime care medicine, sulfonamides are used mainly to treat urinary tract infection as well as upper respiratory tract infections. These drugs have remained popular because they are well tolerated by patients and they are relatively inexpensive. A good example of this is the long tradition of treating leprosy with dapsone, burn with silver sulfadiazine, eye infection with sulfacetamide, etc. The only limitation of their widespread use has been the drug resistance. increasingly prevalent resistance against sulfonamide has, however, gradually limited the use of these sulfonamides. Resistance and also worries regarding allergic side effects has limited or has decreased the uses of sulfonamides in the industrialized world in the last few decades. Dear friends, up till now you have gained a complete idea about history, development, classification, mechanism of action, uses and resistance of sulfonamides. If you have missed any of the module or content, you may log on to our website www.cec.nic.in to download videos, FAQs, LOR and other content so that you can remain updated with the content. Time for you to self-study now. This is Dr. Bhumika signing off. I'll be back with remaining modules of sulfonamides through one more lecture in this series, Sulphonamides 2. Till then, keep studying. Goodbye.